Good evening, everybody, and welcome to our May NRAS live event. I'm Ailsa Bosworth, NRAS's founder and national patient champion, and it's a huge pleasure to welcome our expert guests this evening who will introduce themselves in just a moment. Tonight, we're going to be talking about hand and wrist and foot and ankle surgery. These are topics that I know rather more about than ideally I would like, having had 4 hand and wrist operations and 5 foot and ankle operations. But we have 2 wonderful surgeons with us tonight to tell us more about this kind of surgery. And we've received a huge amount of questions via our website in advance of tonight's event. And I'm not sure that we're going to have time to get through them all, but we'll do our very best. So let me straight away ask our guests to introduce themselves. James, I'm going to come to you first. And for the sake of transparency, I should tell you that James did a complete ankle replacement revision on my left ankle in January this year, and will undoubtedly have to do the same thing on the right ankle at some point. But I'm now pain-free, so good job. So James, please introduce yourself.
Good evening, everyone, and thanks very much for the opportunity to speak tonight. James Davis, I'm a consultant foot and ankle orthopaedic surgeon, have been for 24 years. So I have a huge amount of experience, both good and bad, for you to share tonight.
Thank you. Mahendra, over to you.
Good evening, everybody. It is such a pleasure to be with you all today, and thank you for the opportunity to be here. I'm a consultant plastic surgeon with special interest in hand and wrist surgery. I am doing this practice for last 25 years. Both in hand and wrist surgery, both in the emergency as well as elective setup. So it is nice to see you today. Thank you.
Thank you. And Angela, one of our NRAS members, would you like to introduce yourself?
Hello, I'm Angela. I'm from Dorset. I've had RA for over 22 years, and I've had 2 operations, one on my hands, this hand, I'm waiting for this hand, and one on my right foot, which was done in 2012, and which was fantastic.
Okay, great. Well, thank you all for the introductions. Let's get straight into the presentation. So Mahendra, would you like to go first?
Okay, let's get started. Can we have the first slide, please? Right. Yeah, as I already introduced myself to you, I work at Heatherwood and Wexham Park Hospital. It is part of the Frimley Health NHS Trust. Next slide, please. Yeah, I mean, this was a common scenario for a rheumatoid hand in the past. Thankfully, with the disease-modifying many medications, we don't see often the full-blown picture of this deformity nowadays. Although I still see a few patients from the past, not many, still with a similar deformity with ruptured extensor tendons, distal radioulnar joint arthritis, needing surgery. But I have to say, over the last 5 to 8 years, my surgeries with such deformity have come down drastically. I had a patient almost on every list every week over 8 years ago, but now I do them once in maybe 4 or 5 months with these gross deformities. Very rare. Thanks to all the newly introduced drugs. Next slide, please. Now, wrist fusion is one of the commonest procedure we tend to do with severe wrist joint involvement following rheumatoid arthritis. As you can see here is an example of wrist fusion with a plate. We often don't get such plate fusions in long-standing rheumatoid arthritic hands because the bone is very osteoporotic and the bone quality is very poor to put in screws. So as such, we tend to use a Steinmann pin through the wrist joint to fuse the wrist. In others, we tend to put a hinge joint if the bone quality is good. Next slide, please. I'll quickly go through. Here, there is another example where you can see all the MCP joints involved with gross involvement of the wrist further. And we tend to do Swanson's joint replacements in the MCP joint, which many patients have. Nowadays, I do isolated replacements. We don't get to do all the 4 or 5 at the same time because the extent of involvement has minimized significantly. Next slide, please. Yeah, the thumb-based arthritis is a common entity where we tend to deal with the steroid injections to begin with, and then as with splint support. And if this doesn't respond, then we tend to go to do a trapeziectomy surgery with sling. Next slide, please. This is the Z deformity of the thumb. I particularly brought this up because there were some questions related to Z deformity of the thumb, where there is a hyperextension at the MCP joint and flexion at the distal joint of the thumb, making it difficult and painful to grasp. But surprisingly, in many people, this deformity doesn't cause significant functional impairment. So we have to consider the treatment on a case-by-case basis. We just can't treat the deformity in everybody because to a detriment of the patient's hand function. Next slide, please. We tend to commonly see trigger fingers in rheumatoid patients, where we tend to give steroid injections to begin with. And if it doesn't respond, of course, we don't do surgical trigger release. Usually 70 to 80% of people respond to trigger finger or clicking of the fingers when you see it. Thank you. Next one. Carpal tunnel syndrome is a common problem in many rheumatoid patients, where we initially tend to treat with the steroid injection. And again, if it doesn't respond, then we go for surgical release. Of course, after a course of splint therapy as well. Next slide, please. Rheumatoid nodules, both at the elbow as well as on the knuckles and the distal joints of the fingers, is a common entity. They can become painful. And in such situations where we tend to really cut open that area and excise these rheumatoid nodules. But one important thing here is often the skin gets involved with ulceration, and it is very important that there'll be delayed healing in these areas. Next slide, please. Ganglions or tenosynovitis or synovial swellings are a common entity following rheumatoid. We often see a florid synovitis with the significant swelling on the back of the hand. This synovial swelling, as you know, in rheumatoid, with synovial proliferation, eats away the tendons, causing rupture of the tendons and then finger drop. So in those cases, we tend to buddy strap or buddy repair the extensor tendons in order to facilitate the function. Next slide, please. Sometimes we tend to see Dupuytren's contracture in patients with rheumatoid arthritis. Here, we tend to release it surgically if it is starting to cause significant hand function impairment. Next slide, please. Yeah, here is a patient with significant Dupuytren's contracture where we had to excise the entire entity over the finger and put a skin graft in. They really do well, although post-operatively they need a lot of physiotherapy and occupational therapy input, which is very important. I did not mention earlier, all those surgeries which I mentioned earlier, surgery is only a 50% aspect of management of rheumatoid hand. We need very important input from physiotherapists and occupational therapists to achieve optimal function in all the hands. Next slide, please. Thank you.
Thank you very much. That was great, and we'll come to the questions after we've heard from James. So, James, over to you to do your presentation.
Thank you very much. So, just for filling in the picture, 20 years ago, 30 years ago, treatment of rheumatoid was relatively predictable, as Mahendra has said. The disease wasn't well controlled, so this being basically a soft tissue inflammatory condition led to the ligaments of joints becoming lax, joints becoming unstable. That led to arthritis, along with the inflammation that one has associated with the disease. And so we could predict the deformities and the joints involved. It's less so nowadays, with the joints being protected with modern treatments. So the deformities are less obvious, and it's a little decision to be made between what's inflammatory pain and what's mechanical pain. Surgery works well for mechanical pain, but not so well for inflammatory pain. What are the principles of treatment? Well, we've got to remember that I'm not just treating a foot, I'm treating a whole patient, and the alignment of the limbs make a difference to what I do to the foot. But also, I can put someone out of action quite significantly. So you've got to consider all of these things. Surgery, of course, is the last resort. And when you're thinking about surgery, you're thinking about how you can preserve joints and function, or whether you're going to need to remove joints and fuse them in order to gain correction of deformities or function. So you've got to select approaches that lead to the least time the patient's immobilized. You've got to remember that if we put you off your feet, you're going to decondition. So you've got to keep your strength up, upper limbs and other limb. But if we keep you off for too long, you may lose some reserve and become more permanently disabled. The most important thing is all the decisions we make are shared. And what that means is we've got to individualize the treatments between different patients. So it means listening, examining, discussing, and then deciding together what we need to do. And those treatments are always initially non-operative and then operative. And the whole point of them is relieve pain, prevent deformity, correct deformity if it's there, preserve function, and restore function. It's quite a complex decision-making tree when you're considering treatments. And of course, you'll need other people to help you. Anyone that can help you and makes a difference, I'm happy to work with. Surgery is in yellow, and you've got to make sure you select a surgeon you trust and looks as though they know what they're talking about with this particular condition. In foot and ankle surgery, what we see some people with forefoot disease, that's the front of the foot, some with the back of the foot, and some unfortunately have the whole foot involved. The middle of the foot is relatively rare. What do we do in the forefoot? So this is what we used to be confronted with: significant deformities. You can see the calluses on the sole of the foot round here, very painful, managed with footwear and failed that. This is a more subtle one. There's a bunion there you can see, and a big callosity under the sole of the foot where pressure, and we all know that can be really painful. And those are sort of slightly historic, because this is what we see a lot of nowadays, which is very subtle inflammation and deformity. So we have to change the way we deal with these things. What do we do with the big toe? So nowadays, with the joint being preserved by the various medications you can take, we can treat this like we do a person that doesn't have rheumatoid. If the joint is good and it's mobile and it's not painful, we can correct it by moving the bone across and straightening the toes out. That reestablishes the function of the big toe and protects the rest of the foot. If you've got a more significant problem, a bigger deformity, soft tissues that aren't particularly good, or a joint that's destroyed, then we tend to fall back on fusing the joint. That's making it solid and joining the bones together, a very successful procedure in the rheumatoid patient. What about the small toes and the ball of the foot? This looks relatively innocent, but that can be really uncomfortable when it rubs on your footwear. And there are various methods of treating it. There's the standard method where you take away, as in that picture, the bones in the joint, you straighten it out and you place a wire down the middle of it, either a wire that you need to remove, or nowadays a dissolvable wire that you put within the toe so it has time to resorb and the bone has time to heal. You can do this through little small incisions. This is just a little incision on the top of the toe for that particular patient, and one underneath the toe where you take a wedge of bone out and straighten it out. And that's quite good when the soft tissues are damaged. If you've got lumps and bumps around the feet, you can use the little burr, which this is, under X-ray guidance, just to remove the bone so it's less pressured. And if you've got a problem under the ball of the foot, with the ball of the foot and the metatarsals being somewhat collapsed, you can do this with that little burr, making a cut through the bone, allowing that bone to come up inside the foot and balance with the rest of the bones. The operation previously that Angela had done was a Weil's osteotomy, which is an open operation where you effectively do the same thing that you did with the burr, but you do it with an open fashion, a saw and a screw. Now, some of the reason to try and use the minimally invasive techniques is those wounds are small, the soft tissues have less of an insult, they may heal quicker, and that means that you can get back onto the disease-modifying drugs sometimes more rapidly to control the general rheumatoid flare. What happens if you had a foot like the one I showed earlier? There are various options for that across the ages with all similar success rates. But what we tend to do nowadays is not chop bits of bone away from the big toe, but try and preserve it with fusion operation. And with the smaller toes, we do this now, which is similar to that, but we use the tendon that pulls the toes up in the air to reroute it through the joint to hold the toes in a more stable position. So you can take a foot that looks like that, and when you finish doing the operation, and you can do the incisions for the lesser toes either on the top or the bottom, you can end up with a foot like that. So the other one that we showed earlier, the foot like that, with a similar operation, you can move it to a foot that looks like that. And now that looks like a relatively normal foot, but the most important thing, it's functional. There's no pain. If all else fails, you can go back to basics, which is the Pobble operation. Edward Lear wrote a book, The Pobble Who Has No Toes, and that was popularized. We don't really use that in rheumatoids any further. We do, however, do it a lot in the diabetic population. What about the middle of the foot? Now, this is much easier decision making. You have arthritis with or without deformity. We try footwear and orthotics first. If they're failing, injections often give some relief, but also give us an idea of which joints are causing the problem. And then we fuse the joints either in the position they're in or with correction. Now, that sounds very straightforward, and it is, and there's pictures of it. However, you need to be in plaster for 6 weeks non-weight bearing, and then in plaster after that, or a boot for another 6 weeks, and then weaning out. So it's a major undertaking, which can lead to deconditioning. What about the back of the foot? It's rare in early rheumatoid. It's commoner in females. As we see there, the percentages are low within 5 years, but increase as rheumatoid is around for longer. The Achilles tendon, we've always got to be aware of. Tightness in the Achilles tendon causes problems around the back of the foot. So we often stretch that out or surgically lengthen it. What do we do around the back of the foot? Well, rarely we do soft tissue procedures. It's becoming slightly more common now. We've got better control. You can fuse 1 joint, 2 joints, 3 joints. You can fuse the ankle, or you can fuse every joint. That's not a good operation. It leaves you a very, very stiff foot. It's good for low demand patients, but not people who want to have a reasonable mobility level. And ankle replacements, those are now popularized. What about the tendon, the tibialis posterior? You may not know what that is, but it is the tendon that's injured around with rheumatoid arthritis that causes the foot to become flat. It has a tunnel in which it runs, which has the similar tissue to the joint lining, and it becomes inflamed, stretches the tendon out, and the foot ends up like this foot here. Now, if the joints are good, we can preserve those joints. So we do operations where we break the heel bone here, move it across so it's more underneath the shin bone, and then we take the tendon that operates the tiny little toe ends and we transfer it into this bone here to replace this damaged tendon, and that gives you function back. You have to be quite careful. This tendon can solve the same problems that the original one did, so often we resort to fusing the joints in position so that they won't slip back out of position again. That's called a triple fusion. But again, you're needing to be in plaster for a significant time. What about ankle fusion? Well, ankle fusion has a place. It's usually where the soft tissues are poor. And as you can see from this picture, the soft tissues here are enormous. This is a patient with lymphedema. And we tend to fuse the ankle, because we can do that telescopically. So you put a telescope into the ankle, you use an instrument to remove all the rest of the gristle that's in there, and you end up with this nice yellow bone, and you then place screws in to squash the bones together to allow them to heal. But once again, in plaster, 6 weeks, non-weight bearing, and then in a boot. So it's a relatively involved process. Ankle arthritis is isolated, but can come with other arthritises in the foot. So if you're correcting a foot deformity, like that one 2 slides ago, you might need to fuse the joints underneath the ankle, but the ankle is also arthritic, and you don't want to fuse that because that leaves you with a solid foot, which can be dysfunctional. So then the opportunity arises to perhaps replace the ankle. And that is what we've done here. We fused the joint under the ankle to correct the heel bone back under the shin bone. And then we've replaced the ankle and removed the screws. Excuse me, and we removed the screws. And that gives good function. However, ankle replacements fail. 85% of them will last 10 years, but they will fail in a predictable manner, as this one has. You can see here that this bit should be directly under this bit, and it's not. It's angled inwards, and this represents a failing ankle replacement. So we do have the ability to revise these to more robust ankles to give you stabilization and improve your function. If the bone loss is too great, you've lost a lot of this bone stock around here, you lose the opportunity to revise to an ankle, and we've got to think of other ways of doing that. And we revise those to fusions, but now we're using 3-dimensionally printed technology, which are titanium cages that are built for individuals or based on CT scans. And we fix those in place with this rod through the heel, and that restores function. And you can see that for the sharp-eyed ones amongst you, that's a joint there. That's the head of the talus bone being replaced with titanium, which allows movement within the foot. Thanks very much for your patience and your attendance tonight.
Thank you very much, James. I smiled because I recognised one of those last X-rays. That was mine.
Indeed.
I was a bit, I have to say, I was a bit astonished, because the last time I had a revision to my ankle, I was at least 8 to 10 weeks non-weight bearing, and totally get what you were saying about the loss of conditioning. And when you told me after 2 weeks in January, after you put the new lump of metal in, that I could go home and stand on it after 2 weeks, I really almost didn't believe you. And it took quite a bit of courage to actually, with the plaster on, to go home and actually put that weight on the ankle. And I was astonished that it didn't actually, felt strange, but it didn't actually hurt. But that was a massive improvement, having 2 weeks non-weight bearing than 8 to 10 weeks. So huge change in the technology and the way in which this operation is done. So Angela, can I come to you now before we go into our questions, and just get a sense from you what you've had done briefly, and then perhaps we can talk a bit about how we cope post-operatively, because the surgeons, lovely as they are, don't tend to give you a lot of advice about how you're going to manage when you can't weight bear and so on. So let's hear from you.
Okay, so what can I say? I got diagnosed, and arthritis hit me out of the blue. And within 3 months, I had my diagnosis. But previous to that, I couldn't even get out of bed. Then what I did was I went into total denial because it was so fast. I had my diagnosis in 3 months' time, and then I refused to take the medication. I thought, I'm going to be 1 in 100 and I'm going to get rid of this any which way I can. I'm not going on medication. I took homeopathy, and after 7 years, I was in so much pain, I could barely walk, and the bottom of my foot, my right foot especially, felt like I was walking on razor blades. It felt like I had a stick. I just couldn't manage, and the pain became so intense. And I think it was due to all the inflammation wearing away my joints. I should have taken the medication, but I didn't. I went along the other route. Anyway, the pain was so bad, and Mr. Bowyer recommended the wheels osteotomy. Is that right, James? And debridement. And I go on, say I don't know what it is.
Ailsa osteotomy.
That one. And anyway, so I was scared stiff. I really thought it would all go wrong, and I'd be crippled for life and everything else, because I take everything to the max. And I had it done. I fortunately was able to use a knee stroller after the operation, which was like a little tricycle, and it came in a box, and I hired it. And the knee stroller was unbelievable. It was fantastic. I could whiz around the house. I could go around the supermarket, and it had a little box on the front basket that I could put things in. So that was great, because what happened after my foot operation was my hands were so bad, my wrists were so bad that I couldn't weight bear with the crutches. So when I was at the hospital, they said to me, you can have the NHS crutches. And I said, well, I can't use the crutches. I can't weight bear. So they said, well, the NHS do 2 crutches. They actually give you, there's 2 types. And I tried the other type, and I still couldn't weight bear. So we borrowed a wheelchair from the Red Cross. My husband put me in the wheelchair. We went home. But I got this knee stroller, and this knee stroller was unbelievable, because I could just bend one knee. I had a little, it's just like a bike, really, a little trike, and I could do everything with it. So
and
that
tell us
was
about your wrist, because you've got. I've had a wrist that's completely fused and can't bend at all, but you've had your wrist done, and you've got a bend in it, which is amazing.
So that was done. The foot was done in 2012. As soon as, after I'd recovered, I walked 3,000 feet. I went up mountains, didn't use my walking stick. It was absolutely incredible. The surgery was incredible. Don't be scared, anybody. Have the surgery. Have trust. Find a surgeon. Look at his face. See if you trust him. If you trust him, and you have your backup from your rheumatologist, you have all your medication, get better. And, hopefully you'll be like me, you'll walk 3,000 feet. Anyway, rolling on. December 23, remembering I couldn't, I have a lot of pain in my wrist. I couldn't hold my grandson's hand because he used to pull my hand down. So again, another NHS operation. Both my operations were NHS. I needed both hands done, because both hands were they need doing. The bones have had it anyway. So there's a lot of pain. But because I didn't have this fused 5 years ago, since then the NHS are using this Swiss prosthetic called a Motec. And the Motec, you'll know, James, it's just got a hinge in the middle. So what it means is, instead of being fused, you can only move it to what you could do before the operation, because all your tendons and your muscles have shortened. So don't suddenly expect you're going to have your operation, you're going to be a Thai dancer and be able to do everything. But I can, so this was done December 23. So I can go up, I can go down. And because I've had the radio ulnar joint, that's this sticky out bone there, that one's got a prosthetic, a drug. I can actually twist it. And you probably think, oh, you don't need to twist it. But in actual fact, it's quite handy to twist your wrist because then you can eat instead of going,
Yeah.
you know, like this.
So
I think you had fusion, didn't you, Ailsa?
Yes, a long time ago. My hands were incredibly painful, and my wrists. I was wearing NHS plastic revolting working splints virtually all the time. But once I had the fusion and the exide and the ulnar styloid excision and the tendon repairs and everything, the pain went. And that's really key, isn't it, for surgery? You want the pain to go. Because that's pain and deformity, I think, are the two things from a patient perspective that you really want to get sorted. And I can remember not being able to wear shoes for years and years and years because of the my ankle was over. It had a valgus drift on it, and that got corrected with the surgery, which I was so grateful. I was so thrilled when I could put on a pair of knee-length boots for the first time for years and years. It was very exciting. But one of the things that I think I often get the helpline at NRAS asking me to call people who are about to have foot and ankle surgery because they're always worried. And one of the main things that worries them is, how am I going to get to the loo if I can't weight bear? And I just want to tell people briefly about something called a female urinal, which I found out about through the physio in the hospital on the first foot and ankle operation I had. And I was worried about that too. And I'd never heard of this, but it's a plastic bottle with a wide neck that enables you to pee when you're sitting in a chair or on the edge of the bed or in a wheelchair. And that just solved all my problems. So I could literally be left in the morning with some lunch on the side, my female urinals, and I was then in the front of my computer working for the rest of the day with no problem. And once I'd worked out all the things I needed to do on the first operation, the subsequent ones were less anxious making and less worrying because I'd been through it. I knew what to expect afterwards. But that's always the thing that we get on the helpline, is people worrying about, how am I going to manage? How am I going to make a meal for myself, especially if you're on your own? And the K9 scooter that you've talked about is something that I think works very well for people who are able to bend their knee and put their bad leg on that little scooter thing. But I'm conscious of time, and I do want to get to questions. So let's go to our first questions. We'll do a hand one first. So Mahendra, is it always, this is from an anonymous person, is it always a case of prioritizing function over form when considering surgery for a significantly deformed hand that can still manage many tasks, so it's still functional?
Yes, it's a very quite tricky question where they mention it is still functional. Now, what are the functions? We have to always consider what are the functions are exactly possible in terms of maybe gripping things, holding a pen, holding a toothbrush, or combing, whatever it is. You've got to analyze the functions. They may be able to hold a brush, but if they can't hold it firmly, then it is affecting the function. So it's all, you have to assess case by case basis. Absolutely very important. And what type of grip they have. Is it a tripod grip they have between the thumb and the two fingers, or they have a single grip between the thumb and the index finger? So everything matters. Every minutiae matters. So that is a perfect occupational therapist assessment. Now, in theory, function over form is important, because the form may be all right. If you can't function, you'll regret the operation. Hence, we always give priority for the function. Once the functional aspects are addressed, then secondarily, we also consider the form aspect of it to appear better. Being plastic surgeons, we are very aesthetically conscious as well. Try to make it less deformed or less awkward appearing hand as much as possible. Now, this aspect what has helped us is the disease-modifying medications have decreased the deformities significantly. As such, the main criteria is the function at the moment. They are not significantly deformed to affect their appearance.
Okay.
If it makes sense.
Yeah. James, coming to you, a question here from Patricia Harriman. Are there different types of surgery options available to straighten toes affected by RA? I think you showed us some of those pictures of very nicely aligning toes. Is it all kind of one procedure that no?
So the toe debate is really around, is there a problem at the ball of the foot joint? Is the problem at the knuckle joint, or is the problem at both? Because you have to address all of those. It's no good straightening a knuckle joint up if the toe is in that position and you fuse this joint and the toe's sticking up in the air.
Yeah.
You have to correct it so it's all the way down. But more importantly, if this is sticking up in the air, what it does is it pushes the ball of the foot down into the ground and creates pain there. So you can create a problem from trying simple techniques. So each toe you have to assess individually. So is there pain at the ball of the toe? So at the ball of the foot, where the toe joins the foot. Is that correctable or not? i.e., is it in a fixed position or can I straighten it out? What's happening with that joint and what's happening with that joint? And you address each of those individually. I call it the buffet approach to surgery. You want a toe that's straight and pain-free, and we will do what we need to achieve that.
Okay, thank you. Mahendra, coming back to you, somebody anonymous here, both wrists are surgically fused within 5 years of RA diagnosis. Now 22 years on, they're very painful. Does postmenopause and time passing mean more pain?
Well, it depends why the pain is happening. There may be many reasons for pain. After the wrist fusion, has the implant failed? Is it allowing some movement there causing pain? Yeah, we have to rule out case by case basis. That's the first thing it would come to my mind. Why there is pain? It could be because of the nerve compression. It could be because of the ongoing inflammation in the area. So we have to assess it. So what exactly is the reason? And of course, menopause, osteoporosis, everything adds to the problem. So it is not one factor at that stage. You have to assess it globally and looking at all the aspects of the problem.
Okay, thank you. James, coming back to you, this is a question from someone called Tina. Are heel spurs caused through RA?
So heel spurs, the fallacy of those are that people think you get pain from a heel spur. Less than 1% of heel pain is a heel spur. However, inflammatory arthritis, of which rheumatoid arthritis is involved, have conditions called enthesopathies. Now, that is where tendons or membranes and ligaments join bone, and that becomes problematic. So it may be that there's a plantar spur obvious on an X-ray, but it's probable that that's not causing the pain. The pain is coming from the attachment of the membrane just above it, called the plantar fascia.
Okay. So coming back to you, Mahendra, I'm trying to, some of these questions are a little bit general, if you know what I mean. So what surgery is available for extremely painful wrists and fingers? It's might be a little bit difficult, a bit non-specific to answer that question.
Well, it depends on, again, why is the pain happening? And if it is because of the mobility which is causing the pain with friction of the bones in that area with synovitis, then we have to do synovectomy and we have to remove the affected synovium. Then looking at the bone quality, we need to consider either joint replacement or joint fusion surgically. But before that, we shouldn't forget non-operative treatment, first of all. This all happens, first of all, with I'm only explaining the surgical aspect. But more importantly, the discussion should happen in an MDT setting where the rheumatologists, the surgeons, everybody sit down, and occupational and physiotherapists sit down. How can we manage this non-operatively? Which should be the first question.
Right.
And if they can manage the pain with medications and the splint and get away without surgery, better. But if it is beyond that, then the surgical input comes into play.
Okay. And just thinking about, sorry, carry on.
I hope I have addressed the question.
Well, yes, it was a little bit vague, but I think you have. I mean, interesting to see the difference between my completely fused wrist and Angela's that has got some bend and movement. Is the way Angela's now got a bit of bend and movement in her wrist? Is that the way that the wrist surgery is going now? Or
Ailsa, do you want to show your wrist? Because Angela is also showing it at the
yeah,
same time.
Mine is I can't bend my wrist at all. It's completely fused.
Yeah. Now, that's what it is. See, as I explained to you before, and also James did say earlier, we used to see before the onset of good medications, there is significant bony erosion. And we didn't have bone stock or bone quality to put in good implants with hinge joints in the wrist. That's why, for you, probably because of the bone quality, they put in a Steinman pin, Ailsa. In case of Angela, they have put in a hinge joint, which she correctly explained. With the recent advances, we have got new types of joints. And if the bone quality is poor, we can't put such type of joints. It depends on the bone quality as well. And if this bone stock is good enough to take the implant, as James showed up in a big tripartite joint, which is put in the ankle, the same principles apply to the wrist as well. So we have very wrist joint replacements, which have hinge joints, hinge mechanism, where it will work very well.
Okay, thank you. James, coming back to you, I've got someone here who's got a bit of a longer question. No, this is an anonymous one. I'm waiting for a Fowler's procedure on my foot, and my podiatric surgeon has told me that he will be using a fish mouth incision underneath my toes. Most people I've spoken to since have said that their incisions were at the top of the foot. What are the advantages or disadvantages of using this method? Does that question?
Yes, that's absolutely fine. So that is particular for individual surgeons. Fowler's was described with a plantar incision. It was modified to the Kessel K procedure, which they did at Stammel, which was again a plantar incision, i.e. on the sole of the foot. And most of us, if the quality of the skin is decent, will make a incision on the top of the foot. However, I do both, and I tend to use the fish mouth incision on the sole of the foot when the bones are really, really next to the skin. The skin is awful over the top of them, and we excise that to allow us to reduce the toes down by removing the bone. It all, for me, depends on what the deformity looks like and what the quality of the soft tissues are, because there's no doubt if you make an incision on the top and you straighten the toes down, that incision is under tension and they have a habit of not healing up. Whereas the one on the plantar surface has got a good blood supply. And if you're careful with your dissection and you avoid damaging the nerves, it heals well. So it's reasonable.
Okay. There was another one here. While I'm with you, I'll come to this one. This person says, I had an ankle replaced in 2006, but I'm concerned that it's starting to fail. Gosh, that sounds familiar. What are my options?
So much as Mahendra said, it really is all about the bone stock. And if you remember the last two slides in my presentation, they gave you two options. Ankle revision replacement, if you've got bone stock, is reasonable. You require good soft tissue envelope, good skin, good pulses. If the bone stock is poor and there's nowhere to place the ankle replacement, then you're looking at fusion type procedures. Of course, once again, the decision making is complicated. For us to revise an ankle, there need to be certain parameters. The ligaments need to be in balance, and generally the soft tissues need to be decent. If you lose completely the inside of the ankle or the outside of the ankle bone, then the replacement is deemed potentially unstable, and that leads to early wear and failure. So the decision making is relatively precise based on the individual. But if there's a worry that things are failing, it's better to act early, have some information in the form of x-rays and possibly scans, so that you're not missing the boat of potential revision.
Okay. And maybe this is a question for both of you. So Mahendra, if I come to you first, do general orthopaedic surgeons have enough experience in hand and foot deformity operations, given the decreasing prevalence of these conditions?
Yes. Now, first of all, to clarify, both plastic surgeons and orthopedic surgeons tend to deal with hand and wrist problems. Now, in some centers, plastic surgeons predominate. In some surgeons, orthopedic surgeons predominate in handling this. Now, with there is a lot of focus on doing a number of surgeries in a concentrated place, so that the surgeons also are experienced. With the time passing by, for example, the rheumatoid hands are handled in a particular centralized place, where in our area, so that they are not operated in every place, especially when there are complex wrist replacement surgeries. Yeah. So it is a difficult question, but I think with the evolving time, it is going to be more centralized, where there will be surgeons who are handling such problems more and more, especially with the decreasing prevalence of the advanced rheumatoid problems.
Yes. James, can I come to you on that?
I think the era of the general orthopedic surgeon doing a little bit of everything is almost completely dead. Most departments have specialists in shoulder, foot and ankle, knee, hip. And the majority of foot and ankle surgeons are well trained and will deal with this problem thoughtfully and appropriately. So there's little danger now of encountering someone who is just having a go at things and generally continuing to do the majority of orthopedics.
But have you both seen, I imagine you have, with the advent of the biologics around the turn of the century, have you seen a reduction in the number of orthopedic surgeries and hand surgeries that you're doing?
Yes, but I have to say that, people with rheumatoid now are dealt with very much like we'd deal with someone who hasn't rheumatoid if they're well controlled. Clearly, there are some unfortunate people who can't take some of the biological medications and they're still reliant on steroids, and we still see some of the old deformities occurring.
Right.
But now you deal with people with rheumatoid arthritis in a very similar way to you deal with people without rheumatoid. You don't forget that they have it, but you have significantly more operative approaches open to you because joints are preserved now. So you can correct deformities and leave the joints in good order. The problem is we don't know necessarily how that's going to transpire in the future as to whether the joints do eventually become damaged by the rheumatoid. But, what we're dealing with at the present fit, healthy people who want to lead a normal life. So why do we then confine old-fashioned rheumatoid surgeries to people who are essentially normal as far as their joints are concerned?
Yes, yes. Would you agree with that, Mahendra? Have you seen less of that awful hand deformity that you showed us at the beginning of your presentation?
Exactly. I mean, what James says, I fully agree with that. We almost treat them like patients with osteoarthritis problems, not rheumatoid arthritis, because they have almost similar sort of bone stock to deal with it, soft tissue arrangement to deal with it. So thanks to the medications we have, I mean, occasionally we tend to see gross deformities. In that, I have my trainees coming and watching surgery. Oh, this is very rare surgery, which we used to do regularly in the past, and I
Yeah.
have 4 trainees standing around me watching it,
Yes.
me doing it, because I have the experience from the past.
Yes.
Probably the new consultants have very few people have seen it.
Mm.
So we're completely coming to a different era here now. Thanks
Okay.
to medications.
So we're getting close to 8 o'clock. So a question for both of you. Can you get nerve damage in hands and feet from rheumatoid, or would that only be as a consequence of having surgery? James, come to you first.
So there are conditions associated with rheumatoid mononeuritis multiplex where you get nerve injuries related to the disease. So you can have some form of nerve damage. I see it very rarely. Often nerve dysfunction rather than significant damage is related to incisions during surgical events. We can't always preserve all the little fine nerves that run in the skin, and they can cause areas of numbness and areas of discomfort and pain from little nerve endings that are within the wound itself. But yes, rheumatoid can cause some nerve damage, but it's rare.
Okay. Would you go along with that, Mahendra? Yeah.
Absolutely. Extremely. They are rare. Rheumatoid itself causing, again, thanks to the medications. But surgeries in the hand can cause damage to the nerves if you are not careful. For example, if there's a rheumatoid nodule over the elbow, if you are not careful, you can damage the ulnar nerve, which is just behind the elbow.
Yes.
So it's with rheumatoid itself, we don't see often the significant nerve involvement.
No. Okay. Angela, can I come back to you? Have you had any kind of nerve damage following the surgeries that you've had, or have you got full feeling? You haven't got any numbness or anything in your hands or foot? Or...
So straight after my foot surgery, it was fantastic. Honestly, it was amazing. I was back walking again in no time. And with my hand, the operation, I was really scared about my hand. Both hands needed doing. The right and the left x-rays were really, really bad. And I was told I needed them both doing. But I didn't know which hand to do because they were both bad. And I mean, the operation took 2 hours. There were 4 other ladies in Braintree Hospital, which is an NHS unbelievable hospital. It's like a flagship hospital in Southend. My husband was in a B&B. We could have driven back to Dorset, but they did say to us, stay overnight in the B&B just in case something happens. We came back to Dorset and it was fantastic. I did line up physio with an advanced hand therapist that had helped me before because I had a claw hand, and she gave me exercises to straighten my fingers. So I had Sarah behind me. So straight afterwards, I had my physio. I had fantastic things like a silicone strip, this silicone strip to put on top of the wound to help it heal. And then I was told to use this tongue depressor with cream and make circular movements on the scar to keep the scar tissue loose. And then I had things like a little Neo stretch glove from Amazon. And I used these because the strange thing, I don't know if this happened with you, Ailsa, my hand used to get really cold. And I said to Mr. Packer, I said, when you do your operations, do you tell your patients that their hands get cold because there's so much metal inside? And he laughed and he said, I think it's your circulation and things need to heal up. I got this
a cold. I think a lot of people with RAR.
No, that is called cold intolerance syndrome.
Yeah.
They get really cold. So I just cut a little piece off and make a hole out of one of these stretchy bandages. And then in the winter, I had my little gloves, you see, like that. So it would just hide the scar a bit. I'm not so shy about my scar anymore. I just think, oh, what the hell, you know, it's life, isn't it? I
think we all develop these little hacks, don't we, to help us with the sort of post-surgery scenario. I certainly know that I had a stair lift installed before I had the first foot and ankle surgery, because I knew I wouldn't be able to get up and down stairs non-weight bearing for sort of 12 weeks, I think it was the first time. So yes, we have to work out how we're going to manage, and it is very frustrating, but thanks to you guys, you do a fantastic job. And I must say that all the surgeries that I've had, and James just did the 21st one on me in January, have been helpful. I don't think I can say I've had any surgery that hasn't helped the problem that it was addressing. So I think we are literally a minute away from 8 o'clock. So I haven't been able to get through anything like all the questions, but I'm going to ask both James and Mahendra if they'd kindly answer these, and we'll manage to get them up on the website somehow or other. So we will answer everybody's questions to the best of our ability, but just give us a little bit of time. But it just leaves me now to just give you a couple of bits of information. We are having our JIA, that's Juvenile Idiopathic Arthritis week in July. That's from the 15th to the 21st of July. So watch out on the website for information about that. That's our second website, which is jia.org.uk. And our next live event will be on the 26th of May, and I will be joined by Dr. Eleanor Nikiforou from King's, and we'll be talking about nutrition and diet. And then in July, end of July, the last Wednesday in July, we will be talking about oral health and the impact that has on triggering RA and all things related to oral health. So I'd like to thank you all. Thank you, James. Thank you, Mahendra. Thank you, Angela. You've been brilliant. I hope everybody has learnt a lot from this evening. It's been very informative from my perspective, and it will be available on our YouTube channel, this event, to watch back within the next few days. Thank you to Jeff, our technical guy behind the scenes, for helping us this evening. Thank you all very much indeed, and good night.
Thank you.